and thanks everyone for coming. Thanks for the invitation, Health Scotland. Great to see a big turnout. So Alistair said that there's a momentum around this agenda. I think we're really close to it becoming a tipping point and really close to this becoming an unacceptable part of having a mental health problem. And I think over the next 2 years, and also in Scotland particularly, there's a real kind of drive to do something useful with this. So I'm only going to be able to scratch the surface. I'm going to show you some data about the scale of the problem, highlight some of the issues, try to think about some of the more creative and innovative ways that we should tackle it. But I think today the message is about thinking about the severity of the problem and getting together to try to think about possible solutions. So other people have highlighted this as a kind of social justice issue. Graham Thornycroft, for example, in a very powerful editorial in the British Journal of Psychiatry, said that this constitutes a failure of social policy, a failure of health promotion, illness prevention and care provision, and it's actually a human rights issue that people with major mental illness are dying so much earlier than people without major mental illness. So that was a few years ago that was published, and since then, really, this issue has become more and more prominent. We ourselves have written similar editorials in the British Journal of Psychiatry, this one about multimorbidity and mental health, really highlighting that, of course, major mental illness never happens in isolation. It's extremely common for people to have multiple medical problems as well as a major mental illness. The way services are organised are such that people with major mental illness only get treated often for major mental illness, and the other aspect of their health kind of gets neglected. And there's a debate about the extent to which psychiatry should be covering that, the extent to which GPs should be covering that. But also, importantly, for multimorbidity of this nature, there's a really strong association with social deprivation. And unfortunately, many of our patients come from communities where their circumstances and their opportunities are considerably less than people without major mental illness. And as such, that sort of adds to the burden of disease and the burden of trying to help these people with their overall health. So multimorbidity is part of psychiatry, part of major mental illness. It hasn't been tackled in any shape or form yet, but I think things are about to change. So how bad is the problem? This is a very recent, just last month, I think, last month, published in JAMA Psychiatry. This is a meta-analysis, so bringing together all the data on premature mortality and population attributable risk of dying younger if you have major mental illness. So as you can see, the take-home messages are that 14% of deaths worldwide are attributable to mental disorders, that 67% of people with mental disorders die due to natural causes, and the median years of potential life lost is 10 years. Now that figure's a bit lower because the figure that we often hear, about 15 to 20 years, refers to schizophrenia and bipolar disorder usually, but even depression, as you can see, even anxiety disorders have a substantially elevated population attributable risk. So any kind of mental illness in and of itself increases your risk of dying younger. And crucially from this paper is the message that mental disorders rank among the most substantial causes of death worldwide. So if you ask 100 doctors what are the major causes of death worldwide, I think you'll get cancer, cardiovascular disease, lung disease, etc. I'd be interested to know how many of them actually list mental health disorders as the major cause of premature death. So I think that these data are very, very important in sort of thinking about this issue. What about more locally in the UK? This is information from the South London and Maudslay's database of patients, really just linking people who've come through the service at the Maudslay Hospital and services with death records going forward. And really what it shows, and the highlight, I suppose, is that if you're unfortunate enough to be a woman with schizoaffective disorder and you live in South London, you can expect to live 18 years less than a woman in South London who doesn't have schizoaffective disorder. Likewise, if you have schizophrenia and you're a man, that figure's about 15 years less. And if you have even depression and recurrent depression, is a risk of dying 10 years younger. So quite powerful information. But of course, it's not just restricted to South London. It's issue all over the world, and these are data from Scandinavia, Denmark, Finland, and Sweden, going back many years, actually, going back from 1987 right forward to 2006. And really, the highlight here is that the difference between people who've been in psychiatric hospital at some point and people who haven't, in terms of life years, lost at age 15, is substantial. It's bigger for men than for women. And also, although it is getting slightly better, the gap is really not that different in 2006 from 1987. So there's evidence that even though we've known about this for many years, and there have been some sort of innovative approaches to it, even in Scandinavia particularly, it hasn't really had much of an impact. Some more data, this time from Denmark, and this is data for the whole of the Danish population, compared with people who've had an admission to hospital with schizophrenia. So along the red dot going horizontally is for females with schizophrenia diagnosis. At the bottom are males with schizophrenia diagnosis, and you can see their non-mental health sort of control subjects at the top. And really you can see there's a very substantial gap between men with and without schizophrenia in terms of mortality. Also, crucially, this, although it's getting better for the general population, although people in Denmark and around the world are living longer because of less people smoking, because of people eating better, et cetera, et cetera. Public health interventions that are having a massive impact at a population level are not really feeding through to our patient group, and as such the inequality gap is rising. So all these things that people without major mental illness are able to access are not having an impact for our client group. You might say it's just because of suicide, and the suicide figures are what is behind this, but actually if you take out rates of suicide, you can see that the gap for men actually is even bigger. So it's about cardiovascular disease, it's about heart disease and lung disease and that kind of thing. So I want to talk a wee bit about our work in Glasgow and in Scotland, just to give you a flavour of some of the stuff that we've been doing over the last couple of years. There are very many more studies ongoing and planned in the future. And of course, there are people across the UK who are doing similar work. But I just want to highlight one or two studies. This is a study where we were able to link a cohort of people with psychosis in Glasgow called the CISIS cohort within a safe haven structure to the mortality statistics for people who died, who were part of this psychosis cohort in Glasgow. Several hundred people over the time period that we studied had died, unfortunately, and we were able to map out the relationship between their social circumstances, their deprivation category, so their SIMD category, between living in the most deprived and least deprived communities. And as you can see, there's a big gap. Even in the least deprived, the most affluent communities, there's a gap between people with major mental illness and people living in Scotland and Glasgow. But this gap is very much more pronounced for people living in more deprived communities with major mental illness. So there's a kind of double whammy here in terms of living in places where opportunities for health improvement are less and dying younger with major mental illness. And again, it's not just because of higher suicide rates. If you exclude suicide from those figures, this gap still remains. So I want to highlight our next speaker is Dr. David Shires, and he was one of the lead members of the National Audit of Schizophrenia, published recently in the British Journal of Psychiatry. I'm sure David will mention this, but I just want to highlight some of the take-home findings from that sort of massive cross-sectional analysis of the state of play for schizophrenia across the UK. The key message, I guess, is that the proportion of patients with documented evidence of assessment by their GP of physical health-related problems is here. It's not that easy to read that, so I'll just highlight here what it finds. The body mass index was recorded in only about half of patients with major mental illness in the last 12 months, so that's extremely low, very disappointing. Only 1 in 5 had an evidence of an assessment of all 9 key measures. So it's all very well producing sort of targets for measurement and screening, and then in trying to implement them successfully is obviously a different matter. So 1 in 5 had all 9 key recorded. 53% of those with high blood pressure were receiving an appropriate intervention. So I wonder what people would think if half of people in the general population with high blood pressure were getting the treatment that they should get, and the other half were not. So that's the case for our patients. Likewise, for our patients with high levels of lipids in their bloodstream, only 1 in 5 are on a treatment for that, which would be substantially lower than the general population. So there's a really, obviously it's useful to monitor this, but it's not enough to monitor it. We have to do something about it. And I thought really interestingly from the discussion in this paper was this statement that despite these sort of woeful figures, most people who were surveyed reported they were quite happy with their physical health care that they received. So there's a real issue about our patients sort of advocating that they get more comprehensive health interventions from their GP, from secondary care, etc. And we know that they're not a very forceful group of people sometimes, but it's our job to kind of to advocate on their behalf very strongly. What about in primary care? So we've done a few studies along with collaboration with Professor Stuart Mercer and Professor Bruce Guthrie in Dundee, looking at primary care data in Scotland. One of the studies looked at how common comorbidities are with schizophrenia, looking at a database of 1.8 million GP records, essentially looking down through the records, identifying people with and without schizophrenia, and looking at how common sort of medical comorbidities are in that group. Here's what we found. Perhaps unsurprisingly, very many of the comorbidities were substantially higher, occurring more commonly in people with schizophrenia compared to controls. So that includes Parkinson's, epilepsy, liver disease, inflammatory bowel disease, etc. But despite what we know about the burden of cardiovascular disease, it was surprising to us that in terms of their GP records, the rates of recorded cardiovascular disease amongst people with schizophrenia compared to people without schizophrenia was lower than we expected. And we think that's probably because people with schizophrenia are not having the necessary screening done as commonly, and maybe not having the record done as commonly, and by extension not getting treated for cardiovascular disease as commonly. And it's not just schizophrenia. So we looked also at bipolar disorder and under treatment of cardiovascular disease using this cross-sectional data. Again, just like the picture for schizophrenia, extremely common for people with bipolar disorder, have multiple comorbidities, and as to our surprise, not as commonly recorded to have cardiovascular problems like hypertension, ischemic heart disease, etc. We were able to go a step further for this paper on bipolar disorder. We were able to look at the actual prescribing within the database. And what we found was that despite very high rates of pro-atherosclerotic conditions like smoking and diabetes, it wasn't the case that people were being treated with medication for these conditions as commonly. So there's a substantial inequality in terms of the recording of these comorbidities, but also even when they were recorded, an inequality in terms of the intensity of prescribing for them. So again, it's an example of you can write things down, but you have to actually then do something about it. And it's also, we also looked at people with depression in this group, and the recording for people with depression, it seems to be more comprehensive. So every single one of the 36 possible medical comorbidities was more common in people with depression. So there's something about having a history of depression that makes you at risk of very many multiple medical comorbidities. And that's got implications, I think, even for our understanding of what depression is as a disorder. But that was very striking that all of them were more common. But also, by deprivation, you can see a difference in terms of the number of physical disorders along the horizontal axis, 1, 2, 3, 4, 5, and then the percentage of patients with depression divided up by their socio-demographic characteristics. So people in the most affluent areas are in the bottom, and people in the most deprived areas are on the top. So there's a gap between the most affluent and the most deprived in terms of the relationship of having depression plus multiple medical comorbidities. And this gets back to the original statement I made about multimorbidity and social deprivation and how we need to tackle that, obviously, as well. Another issue is that screening instruments that are used in the general population, like these cardiovascular risk prediction tools, some of you will be familiar with going to your doctor and getting your blood pressure recorded, your lipids recorded, asking about smoking, and then given a statistic about how likely you are to die from a heart attack in the next 10 minutes. But these cardiovascular risk prediction tools probably don't apply to our patient group because they're very heavily weighted towards age. So as your age goes up, your risk of many sort of cardiovascular outcomes obviously goes up as well. But many of our patients are smoking heavily, have unhealthy lifestyles at a much younger age, are on medications that make their risk worse. So we tested within this data set the extent to which conventional cardiovascular risk prediction tools might be useful or not for people with major mental illness. And to cut a fairly complicated slide short, the key message is that probably these tools are not very helpful for our patient group because they're heavily weighted towards age, for example. So we need better, more targeted screening instruments to be able to better accurately predict risk, which are targeted towards our patient group more effectively. So I think that's an important message. We can't often just use what's out there for people in the general population. We have to take account of the special circumstances of our patient group. And likewise at primary care, even though until very recently across the UK there was an incentive for GPs to monitor things like blood pressure and BMI and to record it and to do something about it as part of the QOF payments. We looked in all 4 areas of the United Kingdom, Northern Ireland, Wales, Scotland, England, at whether or not people with major mental illness, say compared to people with other chronic disorders like diabetes and like chronic kidney disease, were they more or less likely to have their BMI and blood pressure recorded? And unfortunately the answer was that even compared to other chronic diseases where this is also incentivized, they were not getting it recorded as often. So even incentives in primary care don't seem to be very helpful for our patient group. And then David will probably mention that very recently this QOF requirement of monitoring was actually been dropped altogether for major mental illness in England, but not in Scotland. So it can only get worse, I think, in that respect. So it's not even an incentivized requirement in England anymore to be monitoring this. So obviously there are all sorts of strategies. Locally in Glasgow, Maura Connolly has been driving forward very impressively as well as nationally the mental health strategy. David, I'm sure, will mention this tool developed by himself and Helen Lester that the Royal College of Psychiatrists are very keen that people use. It's been updated and it should be in your packs actually, so have a close look at that. It's in terms of what the necessary minimum screening and interventions could be done in terms of improving cardiometabolic health. Likewise, people like Sheila Hardy and Richard Gray have developed websites and approaches to primary care for optimizing the monitoring and treatment of major mental illness. This website you can find quite easily. Physical health checks for people with severe mental illness, a primary care guide. There's lots of very useful information and approaches that you might want to look out in terms of improving outcomes for people with major mental illness. I'm going to mention David because really he's been a sort of driving force in recent years in lots of this work and driving this agenda forward, and particularly more recently in terms of highlighting the opportunity of intervening early for people presenting, for example, with first episode psychosis. So there's a really excellent window of opportunity to get in quick with interventions and approaches for people who are first presenting to services, and I'm sure you're going to hear more about that in a moment, including the 5-year target that the HEAL statement has suggested that everyone with psychosis should expect in terms of a minimum satisfactory outcomes 5 years down the line. So in summary, I don't probably need to repeat that premature mortality is a big issue. It's at least 15 years. It might be getting worse rather than better. It's mostly cardiovascular disease related. Clearly, it's a complicated issue and no one single approach will be effective. Social deprivation is an important factor. but also there are multi-level issues to do with access to healthcare, the organisation of healthcare, secondary care and primary care divisions, but also we need population health approaches. There are many barriers, some of them clinician barriers, some of them patient barriers, some of them the way that the health services are organised. And actually what we need are probably a whole sort of raft of innovative, integrated solutions targeting people at high risk, for example, young men who smoke who are presenting to first episode psychosis services with very targeted, innovative treatments, as well as higher level organisational changes as well. I'm probably out of time, so I'll stop there, but thanks for your attention.